So our first speaker is going to be Dr. Tamil, who needs no introduction. Actually, she's a senior consultant, cataract and intraocular lens services from the Eye Foundation group of hospitals based at Coimbatore, a surgical trainer, and she's going to talk on a very important topic, update on modern formula and biometry, preferred practice guidelines, and I think that is so relevant for us if all of us want to be doing premium cataract surgery nowadays. So on to you, Dr. Tamil.
Thank you, ma'am. Good morning, all. Today, in the next few minutes, I'll be covering on modern formulae and biometry. One true yardstick to measure success is how well we are hitting the target refraction. Achieving this is an essential and also a complex aspect of cataract surgery. IOL per calculation is nothing but a simple arithmetic. The only parameter which we measure is the axial length. It is in the estimation of the keratometry, we are forced to make some assumptions. And when we enter the post-op target refraction into any formulae, it starts predicting where the IOL is going to sit in the post-operative period. This is the effective lens position, and it gives the power of the IOL to be implanted. When we hit post-op emmetropia, N6, it could be because of two. It could be because of perfect measurements and formula. In rare cases, it could be due to two errors which could cancel each other. What are the causes when we have post-op refractive surprise? In the past, it could be because of incorrect estimation of the effective lens position, axial length, keratometry, and weak reproducibility of the subjective refraction. But now, the axial length is off the list because of the unsurpassed accuracy of the optical biometer. The rest three remains in the list. Whatever be the principle behind any formula, all of which is trying to predict the effective lens position accurately. So in eye with a normal axial length, the Barrett formulae and the third generation formulae gives the IOL power within a close range. So this tells for an eye with an average axial length and the K, most of the modern formulae works well. What sets the newer formula apart is the extremes of axial length and in the complex eyes. This is because all the third generation formula takes into account of the two variables, axial length and the keratometry, and it assumes that the axial length has a linear relationship with the anterior chamber depth. But this is not so. 7% of the 9% of the hypermetropia and 13.5 out of 15% of the myopia have normal anterior segment. So this is where the third generation formulae misestimate the IOL power. In the long eyes, the Barrett TK and the SRKT suggest an IOL power which is significantly differ. But the one good outcome is that these are low powered IOLs, and hence the effective lens position has less impact on the outcome. The real challenge in these eyes is accurately estimating the axial length, which is get done away with the optical biometry. The short eyes are really challenging, and we could see that there is a gross variation in the power suggested by Barrett TK and Hofer Q. There are two challenges in these eyes. One, they are high powered IOLs. Even a small IOL shift is going to give us a big refractive change. And second thing, the shallow ACD, because it could be because of two reasons. One is the anatomical nature of the eye, or it could be because of the increased lens thickness which could occur with age. All the formula are trying to predict this, and this is why we are underperforming in the short eyes. So what is the best we can expect it to achieve even with the newer formulae is 92% of the target refraction within 0.5 diopters. So how could one choose a formula? We can look into the literature evidence, but we should look that the study is based on a large and a clean data. Otherwise, we can do our own review of results where we are using different formula, and this is one such study done at our institute, and we could see that the Barrett Universal 2 formula is performing excellent across all axial length. Post LVC eyes are really challenging. Multiple studies varied results, even with best outcomes is within 75% of 0.5 diopters of accuracy. Our go-to formula is the Barrett True K formula, and the relevance of TK makes more sense in these eyes, whereas when compared to the virgin cornea, it's going to increase the refractive predictive accuracy in these eyes. Toric IOL use variable toricity ratio, no financial interest. This is a web page from Alcon toric calculator. Whenever we enter the axial length, ACD, the IOL power, the toric calculator should take into account of the effective lens position before suggesting the toric power model. So this is the same. I've entered all the three in web page, the 2 diopters of against rule astigmatism, but just varied the axial length. So for a normal eye, it shows T5 model, whereas for a hypermetropic eye, it shows T4, and for a highly myopic eye, it is suggesting T6. So use a calculator which takes into account of the effective lens position. Even though we nail the ELP on the table, it is going to change in few eyes because of the capsular and zonular issues. So what is the best we can do? Use a formula that is best suited. We use Barrett Universal 2 and it works well in our hands. If you want to compare more than one formula, I would advise you to compare with the Hill RB of 3, and always starts with the accurate measurement. Axial length, it is best measured with optical biometry. If you're going to do an immersion, always look for the quality of the spikes and consistency in the readings. And always measure both eyes, even if the other eye is pseudo-phakic, and validate and check for consistency. Any difference in axial length, K, IOL power between the eyes should be looked and re-measure. And verify the quality of the measurement. The screening opticians who are doing this, in IOL Master, we have this SNR value, which should be more than 2 with green signal, and always have this foveal fixation check. And for keratometry, always look at the LED Myers. It should be crisp and clear. If there is any teardrop sign, ocular surface disease should be ruled out. And also we can look at the standard deviation value, which should be less than 30 microns. In 70% of the eyes, our keratometry value is going to be good. It is only in the 13% where the Myers is going to be irregular. And always view with caution and take additional time and measurement to rule out ocular surface disease and cause for any irregular astigmatism. And this is going to improve our results to a great extent. So it's all about precision and tolerance of measurement before identifying errors. So the future is we have to look for any breakthrough technology to effectively predict the lens position, or else wait for the post-op IOL power adjustment technologies to correct the residual refractive errors. Thank you.
Thank you very much, Tamil, for a wonderful talk, and I'll take some questions since some of the speakers are yet to join. So one question which I'm going to ask you, and I would ask Dr. Puritha to add on. What I would want to ask you is, if you have access to total keratometry, what would it impact more? Would it impact the values, better assessment in a standard IOL power calculation, in a toric IOL power calculation, and post LVC?
Standard power calculation, it doesn't have much effect, but it does matter in toric IOL power calculation, and especially with also in post LVC eyes.
And if we are using immersion, we do not have optical biometer, how would you go about using the latest formulae to get to this?
A few cases we have to use immersion where we are not able to measure the axial length, and with optical biometer. So always when you're taking an immersion value, as I said, look for the quality of the spikes and consistency between the measurements so that the value is correct. And we can enter these values, the axial length obtained from this and the keratometry value obtained by manual keratometry or the optical biometry, into the online Barrett formulae, and we can calculate the power. Even if you're wanted to use a newer formulae, it is available in the APIS's website where you can use it.